Good morning. Today we are fortunate to have Dr. Raghavendra Rao from Manipal, Kasturba Institute of Medical Sciences. I need not introduce Dr. Raghavendra because all of you know Dr. Raghavendra for a long time. I think he is one of the pioneers in immunofluorescence in India, I should say. And he had set up a beautiful immunofluorescence lab in his department. And we all depended on him for a long time for immunofluorescence. And that is not exactly why I invited him for this particular webinar, because he is into this immunobullous disease for a very long time. And he has a very good working knowledge of various immunobullous disorders. And I want his knowledge to be shared to the upcoming generations of dermatologists. Otherwise, I will not be justified by doing this webinar. And Raghavendra was a very busy, he's a very busy person, but in spite of his busy schedule, when I asked him, he readily consented for the webinar. I'm very, very thankful to you, Dr. Raghavendra. And regarding immunobullous disorders, Pemphigus is a very important one, and you all are very well versed, I should say. And you may have questions on immunobullous disorder in university examination. You may have cases in your practical examination. Beyond that, immunobullous disease is a challenge. And most of the time, when we say, oh, this is bullous pemphigoid or this is pemphigus, many a time we may go wrong. So, Dr. Raghavendra is going to tell you about more of investigations in immunobullous disorders. And of course, he may give a few clinical tips for the diagnosis and management. And you can raise your questions. It is a good opportunity, and he is not very freely available. So make use of this opportunity. Over to you, Dr. Raghavendra.
Thank you for the kind words, sir. Thank you very much for the kind introduction, Kaitan sir. It is a pleasure to be here speaking on my favorite topic. So the topic that was given to me is approach and investigations in vesiculo bulbous diseases. So as you know, I will. It may not be possible to give much details about all investigations and approaches. So I will restrict myself to some of the advanced immunological tests that will help us to arrive at the diagnosis in these conditions. So autoimmune bullous diseases, as you all know, are a group of potentially life-threatening conditions where there is formation of blisters in the skin or in the mucosa. Sometimes in a subset of patients will have lesions both in the skin and mucosa. Now, for the purpose of classification, they are broadly divided into two categories based on the level of split. There, one category is called intraepidermal AIBDs, where the level of split occurs within the epidermis. And the other category is sub-epidermal, where the blister formation occurs below the epidermis. Now, Pemphigus vulgaris or Pemphigus group of diseases is the prototype of intraepidermal AIBD, whereas bullous pemphigoid, or simply called as pemphigoid nowadays, is a prototype of subepidermal condition. Now, when we talk about autoimmune conditions, especially vesiculo bulbous conditions, it is very important for us to know the target antigens in these conditions. The target antigen in Pemphigus group of diseases is desmoglein 1 and desmoglein 3. Desmoglein 1 is considered as Pemphigus foliaceus antigen, and desmoglein 3 is considered as Pemphigus vulgaris antigen. Now, these desmogleins are glycoproteins. They are transmembranous glycoproteins where they form scaffolding with the neighboring desmoglein as well as desmocolins. Now, what happens in the disease state is there is formation of autoantibodies, and the antibodies will go and bind to these proteins in the intercellular space, and that in turn leads to a cascade of inflammatory reactions, which ultimately leads to separation of cells. So this separation is the basis of blister formation in Pemphigus, and we call it as acantholysis, where the two keratinocytes get separated from each other. On the other hand, in case of subepidermal AIBDs, the target antigens are present at the dermoepidermal junction, which is otherwise known as basement membrane zone. So for the purpose of understanding, we can probably classify them into 4 different but very important zones. The first zone is on my left are hemidesmosomes, which contains 2 important proteins, BP230 and lectins. These hemidesmosomal proteins are present in the adhesion blocks within the basal keratinocytes. And then we have upper lamina lucida, which has again 2 important proteins, which are transmembranous molecules, BP180 and alpha-6 beta-4 integrins. Now, these are the transmembranous molecule, which means that a part of them is present within the keratinocytes, but major part is present in the intercellular outside the cell. They travel along the lamina lucida, where they connect hemidesmosomal proteins to lower lamina lucida proteins. On the other hand, on my right, you have lower lamina lucida. So we have 2 important proteins here. One is called laminin 332. Other one is called laminin gamma 1. So these proteins also play an important role in certain conditions, as we learn later. So the 4th zone is sublamina densa, which contains 1 important protein, which is called type 7 collagen. So now why you should know about this arrangement of proteins is because this the knowledge of this helps us to subclassify them into different conditions, especially when we do salt split techniques. The proteins which are present in these 2 zones will relocate to the roof of the split, whereas proteins that are present here will be there in the floor of the split. Now, how do we approach to the case of AIBD? The 4 pillars in the diagnosis of autoimmune bullous diseases are clinical information. We need to do histopathological examination. Direct immunofluorescence microscopy is the cornerstone in the diagnosis of AIBD, and also serological test. So now let us go through each of these pillars. The clinical features of AIBD. So when do we suspect a patient is suffering from autoimmune bullous disease? So when somebody has painful oral erosions, which is not subsiding in a reasonably good time, if it is progressing beyond 2 weeks, if it is persisting beyond 2 weeks, then probably we consider the possibility of AIBD. On the other hand, a very classical presentation of any AIBD is the presence of blisters in the skin. So as you can see here, if these blisters are there on the skin in very specific areas, then we sort of very sure that it is a case of AIBD. On the other hand, patient with Pemphigus foliaceus may occasionally present with exfoliative dermatitis-like picture. So they may not present with blisters. They may just have scaling and crusting predominantly over the seborrheic regions of the body. Sometimes it can affect the entire body, leading to erythroderma. So when a patient has erythrodermic features, especially when there are wet scales like this, then we also consider the possibility of autoimmune bullous diseases. Occasionally, about 1/5 of patients, especially in bullous pemphigoid, may present with atypical features. They may present with eczematous pictures. They may present with prurigo nodularis-like picture. So that also is the time when we consider the possibility of autoimmune bullous diseases. So these are different settings, clinical settings, which will tell us that this particular patient may have may be suffering from autoimmune bullous diseases. Now, the second important pillar is histopathological examination, based on which we classify them into either intraepidermal conditions or subepidermal conditions. Now, when we see intraepidermal bullous diseases, then again we need to know where exactly is the blister cavity. If the blister is present just below the stratum corneum, then we would consider the possibility of either Pemphigus foliaceus or its variant Pemphigus dermatoses, or occasionally SAIBD type of IgA pemphigus. If the blister is present within the epidermis, in the mid-epidermal level, then we think in terms of intraepidermal neutrophilic dermatosis type of IgA pemphigus, or when it is suprabasal, just above the basal layer, where the basal cells are separated from each other, giving a row of cornerstone appearance, that is very classical of Pemphigus vulgaris. But paraneoplastic pemphigus, though uncommon, can also have in suprabasal split infiltrate. On the other hand, subepidermal AIBDs are little more confusing because there's a lot of clinical overlap. So it is a real challenge for clinician to make a precise diagnosis because of the overlapping clinical features. This overlapping clinical feature is reflected on histopathological examination also, because all of them present with subepidermal blister. Then further categorization is based on the predominant inflammatory infiltrate. If we see a predominantly eosinophils, then we would consider the possibility of bullous pemphigoid as a first possibility. Occasionally, anti-P200 pemphigoid as well as EPA can have predominantly eosinophilic infiltrate. On the other hand, when we see a plenty of neutrophilic infiltrate in a subepidermal bulla, the first diagnosis that we often consider is linear IgA disease. The second possibility is anti-P200 pemphigoid again. Epidermolysis bullosa acquisita, especially of inflammatory phenotype, can have neutrophils in the blister cavity, and bullous SLE, we should not forget, will have subepidermal blister with neutrophils. A subset of patient will show subepidermal blister, but then there is no inflammatory infiltrate for us to arrive at the precise diagnosis. So these group of conditions are quasi-inflammatory conditions. So when we see quasi-inflammatory subepidermal cleavage, then EBA is the first possibility. The second possibility is bullous pemphigoid, especially when the blister arises on normal-looking skin in case of bullous pemphigoid, in contrast to urticated background. They will not show a lot of inflammatory infiltrates. So this is the broad classification, histopathological classification, which will help us to subcategorize these conditions into different prototypes. But then we should also be aware of non-specific findings, especially in bullous pemphigoid, because as I told you earlier, about 20% of bullous pemphigoid patients may present with atypical features. So they may show just eosinophilic spongiosis in the absence of any characteristic feature of bullous pemphigoid. So this is one of our patients who presented with this kind of urticated annular looking blocks, and then the biopsy that we took showed plenty of eosinophils. There is no subepidermal cleavage, but in these eosinophils, they're present at the dermoepidermal junction, and they start moving upwards into the epidermis, forming eosinophilic spongiosis here. So when we see this picture, this also is an indirect evidence for us to say that this patient probably is in the process of developing bullous pemphigoid. Now, having said that, we should be aware of what are the pitfalls in the histopathological diagnosis. Clinically, most of the time, especially if you are practicing in tertiary care hospital, you may not get an opportunity to see the patient when at the onset of the disease, because they would have consulted many other doctors, including alternative medicine. So they would have applied a lot of topicals, and then when they present to you, there may not be an intact blister. So this one interesting study from Japan, which is published in Journal of Veterinary Pathology, where they have studied about 55 patients of Pemphigus, and you can see here only 3 patients showed suprabasal split in case of Pemphigus vulgaris, and the subcorneal split was seen only in 6 patients in case of Pemphigus foliaceus. So if you rely heavily on knowing the level of split in these conditions, you may not arrive at a precise diagnosis. On the other hand, the information in bullous pemphigoid is not very different. And this particular paper from, again published in JCP, which showed that only 54% of bullous pemphigoid patients showed subepidermal split. So this is something that should be known to us, and then we should proceed very carefully when analyzing these reports. So that brings us to the third pillar in the diagnosis of these conditions, that is direct immunofluorescence microscope. So direct immunofluorescence microscope is the gold standard in the diagnosis of AIBDs. In addition to AIBDs, it also helps in the diagnosis of other important skin conditions such as vasculitis, lichen planus, autoimmune connective tissue diseases, and other diverse conditions such as porphyrias and amyloidosis. Now, what's the principle of direct immunofluorescence microscope? I will be spending little time here. So we have antigens in the skin, which are depicted here, against which autoantibodies are produced in the disease state. And we want to demonstrate these tissue-bound antibodies by taking skin biopsy. Now, to demonstrate the tissue-bound antibodies, what we need to do is we need to use anti-human immunoglobulins, which will go and bind to these antibodies. So these anti-human immunoglobulins are derived from a rabbit. Then these antibodies are tagged to fluorescent dye. The commonly used dye here is fluorescent isothiocyanate conjugate. So when we use these anti-human immunoglobulins, they will go and bind to the antibodies in the skin, and this reaction, antibody-antibody reaction, can be visualized under microscope, which will give you apple green fluorescence. So this is the principle of direct immunofluorescence. Now, what are the types of direct immunofluorescence? So we have direct immunofluorescence, and we have indirect immunofluorescence. The modification of it is called salt split study, which has two subcategories, direct as well as indirect. Now, how do we interpret the result of direct immunofluorescence? We need to look at the site of immune deposits, where exactly these immune deposits are present, whether they are present in the epidermis, whether they are present in the dermoepidermal junction, or is it lower in the mid on the papillary dermis. The pattern of staining is important, whether it is granular staining or linear staining, and the type of immunoreactant which will give rise to positive result. So based on these parameters, we arrive at the precise diagnosis in direct immunofluorescence. Now, salt split study is very important. There are two categories, direct and indirect. In direct, we use patient's skin biopsies and then split it. And in indirect, we use patient's serum. So indirect immunofluorescence is to know the presence of circulating antibodies, and in indirect salt split is done exclusively for patients with subepidermal AIBDs. Now, you also should know about the site of biopsies for direct immunofluorescence. In all AIBDs except in dermatitis herpetiformis, you need to take the biopsy from the lesional skin. If you take biopsy from the lesional skin, the immunoreactants would have been already degraded by inflammatory infiltrate, so you will not be able to appreciate anything. You need to take biopsy a little away from the lesion, about 5 millimeter away from the lesion. So the site which is shown in this diagram. In dermatitis herpetiformis, the ideal site of biopsy is buttocks. In all other conditions such as vasculitis, lichen planus, DLE, you prefer to take it from the lesional skin. In patients with suspected systemic lupus erythematosus, we need to take biopsy from the non-lesional sun-protected site. That will help us to demonstrate the presence of granular staining at the dermoepidermal junction, which is popularly known as lupus band test. So punch biopsy is more than enough. It is optimum for direct immunofluorescence. So few things that you should remember here is, if you are planning to take 2 biopsies, especially for histopathological examination and direct immunofluorescence microscope, the first biopsy should be taken always from for direct immunofluorescence microscope, because if you take the biopsy for histopathological examination from the lesional skin and you take this skin and then dip it in formalin, that formalin contamination will make the biopsy for immunofluorescence useless. So it will degrade all the immunoreactants, and then you will not be able to appreciate the proper staining. The second important thing that you should remember is you should not crush the biopsy sample as much as possible. You have to use a fine needle and lift the biopsy and cut it at the base of the cut it at the base, either in the mid epidermal or deep dermal level, so that the epidermis and dermoepidermal junctions are not crushed. So if you crush the biopsy, it will lead to crushing artifact. Again, might give rise to false positive reactions. Now, if you have taken the biopsy, but you do not have the facility for immunofluorescence, so you need not worry about that. There are good transport mediums. Michel's medium is one of them, which can preserve the immunoreactants safely for up to 28 days. There are certain studies which have shown that up to 6 months, it can preserve the immunoreactants without degradation of these immunoreactants. So that is something that you should be aware of. People from Netherlands have shown us that even normal saline can be used. Normal saline offers certain distinct advantages for Michel's medium because it decreases the background staining of these biopsies. But one catch here is if you are planning to send it in normal saline, it should reach the lab within 24 hours. For example, if you have the facility in your own hospital, and if you take biopsy in the OPD, and then you can ship to the lab in normal saline if you don't have the facility for Michel's media. We also have shown that honey can be used as a transport media. In the pilot study, which was published in JAD, we showed that honey is a good transport media and can preserve the immunoreactants for about 2 to 3 weeks. And then we compared it with Michel's media, and then again it was proved that in the study that honey can preserve the immunoreactants safely for 2 weeks, after which there is degradation of immunoreactants. So that is something you can use. The honey that we used in the study was procured from the departmental store. So you can procure the honey and then ship the biopsy to the lab. One thing that you should remember is honey being more viscous, biopsy sample may not get immersed completely in honey. So we have the ideal technique would be a sandwich technique where you take a vial containing honey and then put the biopsy and pour little amount of honey, so that honey is sandwiched between 2 layers of biopsy is sandwiched between 2 layers of honey, so that honey maintains proper moisture. So that is something that you can use for your day-to-day practice. So what are the findings? In Pemphigus group of diseases, you will see intercellular staining, which characteristically described as fishnet or chickenware appearance. So this is most predominantly seen in the IgG class of immunoreactants. In about 50% of the patients, especially in the active phase of the disease, they will also show C3 deposits. So IgG and C3 are the predominant immunoreactants in case of Pemphigus. Other class of immunoglobulins are seen in about 20% of the patients, such as IgA or IgM. Now, based on immunoreactants, based on direct immunofluorescence microscope, can we differentiate Pemphigus vulgaris from Pemphigus foliaceus? So this is something that we often get inquiry from practicing doctors or practicing, the junior residents who have sent the biopsy. Is it Pemphigus vulgaris or is it Pemphigus foliaceus? The diagnosis of these conditions is mostly clinical. Direct immunofluorescence microscopy is not the test to differentiate these two major subtypes of Pemphigus. But occasionally, we might see this kind of picture where you have intercellular staining in the epidermis, but the entire epidermis is separated from the basal layer. So when we see this picture where there is a suprabasal cleavage, where there is staining on both sides of the split, then we are sure that it is Pemphigus vulgaris. On the other hand, in case of Pemphigus foliaceus, as we know that the desmoglein 1 is the target antigen, and it is richly expressed in the upper layer of the epidermis. So as you go down towards the basal layer, the intensity of staining comes down. So when we see this kind of picture, we know that this is Pemphigus foliaceus. So in Pemphigus foliaceus, the intensity of staining is very intense in the upper epidermis, and as we move down, it becomes less intense. But in general, we would not use direct immunofluorescence microscope to differentiate vulgaris from foliaceous, it is mostly clinical or serological. Now, the two subtypes of pemphigus that you should know are paraveneoplastic pemphigus and pemphigus erythematosus. In these two subtypes, in addition to intercellular staining, you also will see staining at the dermoepidermal junction in linear pattern in case of PNP, and in case of Pemphigus erythematosus, you will see granular staining similar to systemic lupus erythematosus. So these two subtypes will show you dual staining both in the epidermis as well as in the dermoepidermal junction. So with that information in the background, let us see how we can summarize the findings in intraepidermal AIBDs. So you have two staining patterns. Either you will see intercellular staining or you will see intercellular plus BMZ staining. So when we see intercellular plus BMZ staining, we have two differential diagnoses in paraneoplastic pemphigus as well as pemphigus erythematosus. In these two entities are clinically very distinct. Paraneoplastic pemphigus will have recalcitrant mucositis, which is not affected in case of pemphigus erythematosus. PNP will have polymorphous skin eruptions, whereas pemphigus erythematosus will present predominantly with SLE-like rash, like malar crusted erythematous plaques on the malar region. So, to further confirm this, we need to do other additional tests in the form of indirect immunofluorescence using rat bladder as a substrate that will help us to identify PNP antibodies. You can also do antinuclear antibodies if you're suspecting pemphigus erythematosus, as 50% of these patients may have circulating autoantibodies. Immunoblotting is something that will help us to identify the target antigens in case of PNP. On the other hand, intercellular, if the staining shows only intercellular staining, if it is seen predominantly with IgA, then you would consider the possibility of IgA pemphigus. On the other hand, if it is seen with IgG with or without C3, then you have two possibilities, either pemphigus vulgaris or pemphigus foliaceous. So we can go ahead and do desmoglein ELISA here, or we can also do indirect immunofluorescence, either using monkey esophagus or normal human skin. So on the other hand, moving on to this next category of conditions, which is subepidermal AIBDs. So subepidermal AIBDs will show you two different patterns from direct immunofluorescence. One is called linear staining of BMZ with IgG with or without C3, or in subset of patients, there will be only IgA staining. Or it can show granular staining, which is mostly concentrated over the tip of dermal papillae. As you come down to the irritated edges, the staining becomes less intense. So when we see this pattern, we are almost certain that this patient is suffering from dermatitis herpetiformis. On the other hand, a linear staining pattern is very tricky situation because all the conditions will present with linear staining of BMZ. So this is because these group of conditions, there are at least 6 important conditions which will target antigens which are located in different spaces within the dermoepidermal junction, as we discussed earlier. Now, can we use direct immunofluorescence test to subcategorize these conditions? So, serration pattern analysis has been shown to be an effective tool to differentiate subepidermal AIBDs. So, based on this, BMZ staining can be further differentiated into N-serrated or U-serrated pattern. N-serrated pattern shows arches are closed at the top, whereas in U-serrated pattern, the arches are closed at the bottom. So that is the difference between these two. So when we see N-serrated pattern, that is very characteristic of pemphigoid group of diseases, including bullous pemphigoid or anti-P200 pemphigoid, whereas U-serrated pattern is very classically seen in case of epidermolysis bullosa acquisita, okay, and sometime in case of bullous SLE. So serration pattern analysis is a tool based on direct immunofluorescence which will help us to subcategorize these conditions into N-serrated and U-serrated pattern. The fourth and the last pillar in the diagnosis is serology. Serological tests are very important in the diagnosis because they help to detect the circulating antibodies. They give information about the antibody burden in the body. So they will have prognostic importance with effective treatment. If the patient is responding to treatment, then clinical activity of the disease will come down. This, along with there will be reduction in the antibody titers in the patient's blood. They also help in the subclassification of AIBDs, especially in case of subepidermal AIBDs. We classify them into roof staining or floor staining, and it also helps in the detection of target antibodies, antigens. So, what are the different techniques? Indirect immunofluorescence is a immunofluorescence-based technique, and that is available in our country in most of the centers. ELISA, commercially, ELISA is available. We'll talk about this in a little while. And immunoblotting is required for the diagnosis of certain conditions, especially paraneoplastic pemphigus or antipyretic pemphigoid. Unfortunately, this is not widely available, and there are very few research laboratories across the world which offer these techniques. Now, indirect immunofluorescence is based on patient's blood. So you need to draw blood and separate the serum and then incubate the serum within appropriate substrate. Now, what's the ideal substrate? For Pemphigus group of conditions, Pemphigus vulgaris, the monkey esophagus is the optimal substrate. We can also use normal human skin that is considered as optimal substrate for Pemphigus foliaceus. Rat bladder, which contains transitional epithelium, is an ideal substrate for paraneoplastic pemphigus, and salt split skin is an ideal substrate for all subepidermal conditions. So this is what you expect to see in case of Pemphigus group of conditions. This is the oral mucosa. We did study the utility of oral mucosa as a substrate for indirect immunofluorescence. This is what we got to see. And monkey esophagus is now available commercially, and we also use monkey esophagus to demonstrate the Pemphigus antibodies. This is the classical pattern, fishnet pattern on indirect immunofluorescence in monkey esophagus. Now, subepidermal conditions, as I told earlier, shows a lot of overlapping clinical features. So we need to arrive at the precise diagnosis so that prognosis can be explained to the patient and appropriate treatment can be offered, because not all patients will require immunosuppressive treatment or high dose of systemic steroids. So to arrive at the precise diagnosis, salt split study is considered as one of the best technique to subcategorize this condition. So this technique is very simple. We need to take normal human skin, incubate the normal human skin in 1 molar sodium chloride, and when we do that, we need to incubate for 24 hours. And when we incubate and then take forceps and gently tease the skin, the separation occurs at the level of lamina lucida. Few antigens will relocate to the roof of the split. So this will show a roof staining pattern or epidermal staining pattern, and there are these remaining antigens will remain at the base of the split. So this will show a floor staining pattern. So the conditions which target antigens which are present in this part of the epidermis, that is hemidesmosomal and upper lamina lucida region, will show you roof staining pattern, and conditions which target antigens present here in the lower lamina lucida or sublaminar denser region will show you floor staining pattern. Now, what are these conditions? So this is what you get to see. So you can see here a very nice linear BMZ band going to the roof of the split, and the entire there is separation of the epidermis from the dermis. This is the blister cavity, and there is no staining at the floor of the split. On the other hand, in case of dermal staining pattern or floor staining pattern, so we get to see linear deposition along the dermal side of the split. So when we see epidermal split or roof staining pattern, we think of the possibility of bullous pemphigoid, pemphigoid gestationalis, a subtype of mucous membrane pemphigoid, or linear age disease. On the other hand, in floor staining pattern is not characteristic of any particular condition. These are the 4 conditions which can give rise to dermal staining pattern or floor staining pattern. So to summarize the findings in subepidermal conditions, we have linear staining pattern or granular staining pattern. Granular staining pattern is characteristic of DH, so we can sign of the report as dermatitis herpetiformis. Whereas linear staining pattern, we need to see whether it is seen with IgA or with IgG and C3. If it is seen with IgA, then the next step would be to do indirect immunofluorescence on salt spit technique, salt spit skin, and see if it goes to the roof or the floor. So if it is seen with IgA, so if you see epidermal or roof staining pattern, then the diagnosis would be linear IgA disease. On the other hand, if you see dermal staining pattern with IgA, this condition is now called as IgA-APA. So previously, if you read the textbook, these the two subtypes of linear IgA disease were known as lamina lucida type and lamina densa type. The lamina densa type of linear IgA disease target type 7 collagen, and now it is called, expert feel that the better terminology for that is IgA-APA rather than lamina densa type of LAD. So when we see IF on with IgG, then again you have to check whether it is roof or floor. So as we discussed, all Pemphigus group of conditions will show you roof staining pattern, and then the next step would be to identify the target antigens. For that, we need to do BP ELISA. On the other hand, dermal staining pattern is not characteristic of any one particular condition. These four important conditions will give rise to floor staining pattern. So we need to confirm the diagnosis by doing additional investigations, which are serration pattern analysis, which will show you N-serrated or U-serrated. So you have a patient who shows dermal staining pattern and U-serrated pattern, then the diagnosis is EBA. On the other hand, if you have a patient who shows dermal staining pattern, but N-serration pattern on serration pattern analysis, then you will consider the possibility of anti-P200 Pemphigus. So that is how you have to interpret the result correctly and arrive at the diagnosis. So I have so far discussed about different stepwise approach to the diagnosis of these conditions, but now we have the provision for single-step serological approach, where you just have to add one drop of serum into the commercially available kits, and that will help us to show know the staining pattern as well as they identify the target antigen. So there are two set of investigations that are commercially available now. One is called Multiplex Indirect Immunofluorescence. The other one is called Multiplex ELISA. So Multiplex IF is Biochip mosaic slides. These are commercially available. I will show you how to interpret the result there. And these are the two companies that produce these ELISA kits. These are very simple. You will see how they will help with the diagnosis. So the first one will be indirect immunofluorescence based on Biochip mosaic slides. So each mosaic slide has got 5 to 10 incubation field. So this particular is called one incubation field. So it will have at least 5 or sometimes 10 incubation fields, and each incubation field will have 6 windows. So each window is impregnated with a very specific substrate or a protein, recombinant protein. So it has monkey esophagus, it has got salt split skin, it has got desmoglein 3, it has got desmoglein 1, BP180, and BP230. So when we want to use this, we just have to add a drop of patient serum, and it will tell us whether this particular given serum has Pemphigus or bullous Pemphigus. So this is, we did a study comparing the Biochip mosaic with that of conventional indirect immunofluorescence, and this is what you get to see. In case of Pemphigus vulgaris, you can see this is the monkey esophagus showing intercellular ICS staining pattern in a fishnet pattern. This is desmoglein 1 and this is desmoglein 3. So it will, mosaic Biochip slides will tell us the staining pattern as well as it will identify the target antigens. On the other hand, this is bullous Pemphigus showing roof staining pattern here in salt split and a BP180 positivity and BP230 positivity. So that helps in the identification of target antigen. Now, the important drawback of this is it will not help us in the diagnosis of other classes of subepidermal condition. For example, it will not help us to diagnose paraneoplastic Pemphigus. It will not help us to diagnose EBA or DH. So for that, the Euroimmun has come up with extended mosaic biochip slide, which has got additional antigens that will help in the diagnosis of other conditions such as EBA or paraneoplastic. Unfortunately, the extended biochip is not yet available in India, but the Biochip 7 series is available and it can be used. On the other hand, the Multiplex ELISA again is based on a similar technology where the wells are impregnated with different recombinant proteins, and in using single drop of patient serum, we can tell whether the patient has got these antibodies against one of these proteins. So it has got type 7 collagen, so EBA can be diagnosed. It has envaplakin, so we can diagnose paraneoplastic pemphigus. It has desmoglein 1 and 3, so we can diagnose pemphigus. It has BP 180 and BP 230, so we can diagnose bullous pemphigus. So this is a very simple single-step technique which will help us to diagnose the particular condition using a small quantity of patient serum. So to conclude my talk, AIBDs are a heterogeneous group of conditions which show clinical and pathological overlap. There is atypical presentations one should be aware of. It occurs mostly in case of bullous pemphigus. About 20% of them shows atypical features, and that adds to the diagnostic challenge. Precise diagnosis is important for prognostication and for better patient care. So that is why laboratory investigation should be done in all patients with AIBDs. Laboratory tests are supplementary to each other and they are not substitute, because you cannot say that just because there is one test is positive, I will this confirms the diagnosis. As we have seen in the previous slides, that even if it shows one important feature, for example, BMZ staining in direct mammography, the salt spirit can show you either roof staining or floor staining. So all this information will help us to arrive at the precise diagnosis. Among all the tests, DF remains the gold standard test in the diagnosis and should be done in all patients with AIBDs. Serological test helps to identify the target antigens, and in some cases, they also help us to detect the antibody burden in the body. So with that, I will conclude my talk. And this is the book that we wrote. We have edited. This is IDWell, a textbook of Pemphigus and other AIBDs. So you can get a copy of this book and go through the chapters. It is written by multiple authors across the country, and it has got all the information that one needs to know about AIBDs. Thank you for your kind attention. If there is any question, I will be happy to answer.
Thank you, Dr. Raghavendra. It's a very informative talk. You put everything in correct perspective, and the students are very fortunate to have a comprehensive knowledge of autoimmune blistering diseases. I am very grateful to you, Dr. Raghavendra.
Thank you, sir.
Dr. Raghavendra, on behalf of the student community, as well as on my own behalf, as well as the Histopathology. Thank you, Dr. Raghavendra.
Thank you, sir. Thank you very much for the opportunity.
Thank
Have
you.
a nice day, sir. Thank you.
Thank you.
Thank you, doctors. Thanks for giving wonderful opportunity for our Histopathology. So Histopathology is always committed for the academic-oriented benefit of our PGs, and Histopathology extend our gratitude to the course director, Dr. Ketan sir, to create such wonderful speakers and create such wonderful topics for the benefit of our postgraduates. And especially we are extend our gratitude to the speaker, sir, Dr. Raghavendra Rao sir, has given us a lucid presentation benefit of the PGs and shared his experience across the country. Almost 58 people, 68 PGs were attended across India. Thank you very much, doctor. And the pages, we are requesting you to kindly share the forthcoming programs also. The next program will be on May 11th. The invitations and everything will you reach shortly. So please inform your other colleagues also to join the forthcoming programs. The recorded version is available with the Histopathology people. Kindly get the link with the Esos Pharma people. Thank you so much, doctor, and have a wonderful day to all. Thank you, doctor.